This module was prepared by Dr. Faith Villanueva and Dr. Armin Masbang. This presentation was made for specialists, general practitioners, and allied health professionals. Evidence summaries are based on the best available scientific evidence at the time of formulation of the guidelines. There are some limitations in aspects of screening the information. I present a systematic synthesis of evidence addressing immunization in adults. Appraisal of best available evidence on 8 identified clinical questions was done following the widely accepted grade approach evidence to detection framework criteria. Recommendations shall hold and will be updated after 3 years or when new evidence becomes available. The assessment of the quality of evidence used the grade approach. For today's session of Adult Immunization Series, I am going to tackle about human papillomavirus infection as a vaccine-preventable disease. This is based on a guide to the Philippine Guidelines on Periodic Health Examination or PHEX recommendations, immunization for adults for 2022. Here are the summary of recommendations for human papillomavirus vaccine. Among apparently healthy asymptomatic females aged 18 to 26 years who have not been vaccinated or who have not yet completed the vaccine series, we recommend HPV vaccination with moderate certainty of evidence and strong recommendation. Among apparently healthy asymptomatic males aged 18 to 26 years who have not been vaccinated or who have not yet completed the vaccine series, we suggest HPV vaccination with very low certainty of evidence and weak recommendation. Among apparently healthy asymptomatic adults aged 27 to 45 years, we suggest against routine catch-up vaccination. The decision to vaccinate people in this age group should be made on an individual basis with low certainty of evidence and weak recommendation. Among pregnant patients, we suggest against HPV vaccination with low certainty of evidence and weak recommendation. Among apparently healthy asymptomatic sex workers, there is insufficient evidence to recommend HPV vaccination, and this is a very low certainty of evidence. The consensus panel considered the following when formulating these recommendations. First, the evidence showed that the optimal time for HPV vaccination to yield maximum effectiveness is before an individual's sexual debut. However, when studies included in the evidences base did not explicitly mention how HPV naivety was identified. Although bivalent HPV vaccine is still available in the country, the evidence-based included studies only on quadrivalent and nonavalent HPV vaccines. No specific recommendation was made by the panel on which type of HPV vaccine should be used, citing that it should be a shared decision-making between the patient and the physician. Factors that should be considered include HPV naivety and risk of exposure of the patient, the cost, and the availability of the vaccine, among others. Human papillomavirus is regarded as the most common viral infection affecting the reproductive tract and has been established to cause a variety of conditions for both men and women. Persistent infection with a specific type of HPV may lead to precancerous lesions that may eventually develop into cervical cancer in women when left untreated. It is also associated with oropharyngeal and anogenital cancers in both men and women. Worldwide, HPV type 16 and 18 are directly responsible for about 3/4 of all cervical cancer cases. In the Philippines, as of 2019, the annual number of cervical cancer cases is estimated to be at 7,190, with annual deaths due to cervical cancer at 4,088. Cervical cancer is the second most common cancer in females aged 15 to 44 years, and data on anogenital cancers other than cervical cancer are limited, but there is increasing evidence that strongly associates HPV DNA and infection with the development of anal, vulvar, vaginal, and penile cancer. Different HPV types have varying propensity to infect certain body parts and develop into different associated diseases as shown in this table. HPV type 16 has the highest propensity to progress into cancer. It may infect the anogenital and other mucosal surfaces such as your oral mucosa. Specific HPV genotypes that cause persistent infection that ultimately progress to cancer include the following types: 31, 33, 45, 52, and 58. Meanwhile, HPV types 16 and 18 cause majority of the anal cancer cases and a significant proportion of oropharyngeal cancer, vulvar, vaginal, and penile cancer. Bivalent vaccine covers type 16 and 18. The quadrivalent vaccine targets HPV types 6, 11, 16, and 18, while the nonavalent vaccine targets types 31, 33, 45, 52, and 58, in addition to the 4 types covered by the quadrivalent vaccine. A literature search was made on the benefits of HPV vaccine for adults. This also includes studies comparing the different HPV vaccines in terms of the safety and efficacy. This is a study on the efficacy outcomes of HPV vaccines among immunocompetent females aged 16 to 26 years old, comparing quadrivalent HPV versus placebo for HPV 16, 11, 16, and 18 related outcomes. The studies showed it favors quadrivalent over placebo in preventing 6-month persistent infection, cervical intraepithelial neoplasia or CIN, vulvar intraepithelial neoplasia or VIN, and anogenital warts. This is a study on the efficacy outcomes of HPV vaccination among immunocompetent females aged 16 to 26 years old, comparing nonavalent HPV versus quadrivalent HPV for HPV 31, 33, 45, 51, and 58 related outcomes. The study showed it favors nonavalent over quadrivalent in preventing 6-month persistent infection, CIN, or VIN. In terms of safety outcomes of HPV vaccination among immunocompetent females aged 16 to 26 years old, comparing quadrivalent versus placebo, there's more overall local or injection site adverse events on the quadrivalent exams as expected, but there's no difference in terms of overall systemic event, general symptoms, serious adverse events at any time, nor deaths. Likewise, in terms of safety outcomes of HPV vaccination among immunocompetent females aged 16 to 26 years old, comparing nonavalent HPV versus quadrivalent HPV, there's more overall local or injection site adverse events on the nonavalent. But there's no difference in terms of overall systemic event, general symptoms, serious adverse events at any time, nor deaths. In terms of efficacy outcomes of HPV vaccine among immunocompetent males aged 16 to 26 years old, quadrivalent versus placebo for HPV 6, 11, 16, and 18 related outcome, it favors quadrivalent over placebo in terms of 6-month persistent infection, external genital lesion, condyloma acuminatum, penile intraepithelial neoplasia, and anal intraepithelial neoplasia. In terms of efficacy outcomes of HPV vaccination among immunocompetent males aged 16 to 26 years old, comparing nonavalent HPV versus quadrivalent HPV for HPV 31, 33, 45, 51, and 58 related outcomes, there were no direct evidence found. In terms of safety outcomes of HPV vaccination among immunocompetent males aged 16 to 26 years old, comparing quadrivalent HPV versus placebo, there's more overall local and injection site adverse events on the quadrivalent exams as expected. But there's no difference in terms of overall systemic event, general symptoms, serious adverse events at any time, and deaths. In terms of safety outcomes of HPV vaccination among immunocompetent males aged 16 to 26 years old, comparing nonavalent HPV versus quadrivalent HPV, in terms of overall local and injection site adverse events on the quadrivalent exams, as expected. But there's no difference in terms of overall systemic event general symptoms, serious adverse events at any time, and deaths. In terms of efficacy outcomes of HPV vaccination among immunocompetent females aged 27 to 45 years old, comparing quadrivalent versus placebo for HPV 6, 11, 16, and 18 related outcomes, it favors quadrivalent over placebo in terms of 6-month persistent infection. However, there's no difference in terms of CIN and anogenital warts. In terms of safety outcomes of HPV vaccination among immunocompetent females aged 27 to 45 years old, comparing quadrivalent versus placebo, it shows that there were more significant events in quadrivalent in terms of adverse events and injection site, but there's no difference in systemic adverse events and discontinuation due to adverse events. Regarding the efficacy outcomes of HPV vaccination among immunocompetent males aged 27 to 45 years old, no studies were found on the efficacy of quadrivalent HPV for HPV 6, 11, 16, and 18 related outcomes. There's also no studies found on the efficacy of nonavalent HPV for HPV 31, 33, 45, 52, and 58 related outcomes. Study protocols on HPV-4 trials excluded women who are pregnant. However, 3,819 patients in these trials have reported at least one pregnancy. Adverse outcomes, that is, having a cumulative spontaneous abortion, late fetal deaths, and congenital anomalies, were observed in 22.6% in the HPV-4 group and 23.1% in the control or placebo group. Congenital anomalies were observed in a total of 45 pregnancies that occurred in females who received the HPV-4 vaccine, and 34 cases occurred in those who received the control or the placebo. Currently, HPV vaccine, that is, the quadrivalent or nonavalent, is not recommended in pregnant patients due to limited safety information. However, available data on the inadvertent use in women who were found to be pregnant after initiating the vaccination series does not indicate any increased risk in adverse pregnancy outcome with HPV vaccination. The remainder of the vaccination series is recommended to be completed when the woman is no longer pregnant. No studies looked into the efficacy and safety of HPV vaccine among sex workers. As discussed, clinical studies have shown that the optimal time for HPV vaccination to yield maximum effectiveness is before an individual's sexual debut or in individuals who have not been infected with HPV, meaning HPV-naive patients. Available evidence on the HPV vaccines have shown its role as prophylaxis against HPV infections, but it does not affect existing infections. A population-based case-control study by Silverberg et al. That assessed the effectiveness of quadrivalent in catch-up vaccination, meaning vaccinating after the age of 14 years, against CIN2+, and CIN3+, showed significant protection among women offered the catch-up vaccination at age 14 to 20 years old. This table summarizes the current unit costs of quadrivalent and nonavalent vaccine in the Philippines. The quadrivalent vaccine cost ranges from 562 and 50 centavos to 4,800 pesos per dose, while the nonavalent vaccine cost ranges from 6,750 pesos to around 10,125 pesos per dose. A study done in 2018 by Santhanes et al. Looked into factors affecting HPV vaccine hesitancy among women in the Southeast Asian and Western Pacific regions. And they found out that the concerns on adverse events of vaccination, shyness, fear of needles, and perceived embarrassment of receiving the vaccine were some of the highlighted issues in the population studied. Additionally, participants were reluctant to pay for the full course of the vaccines at the prevailing fair market price. The participants were influenced by recommendations or opinions of others, such as family members, friends, and healthcare providers. A study Young by et al. In 2010 on HPV vaccine acceptability among Filipinos found that the decision to get HPV vaccine was influenced by several factors: their mother and or husband or partner, knowledge that they can get protected from having HPV vaccination and cervical cancer, and vaccine safety. Female physicians were more likely to be trusted as a healthcare provider compared to a male physician in terms of providing HPV vaccine-related information, as well as whom they would be willing to receive the HPV vaccine from. Recommendations from other groups? Well, PSMID recommended both quadrivalent and nonavalent HPV vaccines. Both vaccines are effective in preventing cervical cancer and anogenital warts among immunocompetent adult females and can be given until 26 years old with strong recommendation and high quality of evidence. For ACIP, children and adults aged 9 through 26 years, HPV vaccination is routinely recommended at age 11 or 12 years. Vaccination can be given starting at 9 years. Catch-up HPV vaccination is not recommended for adults aged 26 years and above. Instead, shared clinical decision-making regarding HPV vaccination is recommended for some adults aged 27 through 45 years who are not adequately vaccinated. HPV vaccines are not licensed for use in adults aged more than 45 years. In Australian Immunization Handbook, vaccination of adults aged more than 19 years against HPV is not routinely recommended. However, some adults may benefit from HPV vaccination. When deciding whether to vaccinate adults, consider the following. 1. Their likelihood of previous exposure to HPV and their future risk of HPV exposure. Guidance on HPV vaccination in European Union countries show that HPV vaccine is efficacious for at least 6 years in preventing 6-month persistent HPV infection and high-grade cervical lesions due to types 31, 33, 45, 52, and 58 in females 16 to 26 years old not infected with HPV at the time of vaccination. There's no direct evidence of efficacy of nonavalent HPV vaccine against HPV-related infection and illness in males. The recommended adult immunization schedule in the US for up to age 26 years, 2 or 3 dose series depending on age at initial vaccination or condition. For age 15 years or older at initial vaccination, 3 dose series at 0, 1 to 2 months, and 6 months. Age 9 to 14 years at initial vaccination, receive 1 dose or 2 doses less than 5 months apart and 1 additional dose. At age 9 to 14 years at initial vaccination and receive 2 doses at least 5 months apart, there's no additional dose needed. There's also called the interrupted schedule wherein you don't need to restart. For those who are 25 to 45 years, this is based on the shared clinical decision making and you may give a 2 or a 3 dose series. For those with immunocompromising conditions, including HIV, you may give a 3-dose series even for those who initiated the vaccination at age 9 through 14 years. With that, this is the module on HPV vaccine, and these are the references cited in this module. Thank you and have a good day.